Good afternoon. So I'd like to continue the performance of Lithuanian team, and as Algirdas nicely mentioned, that we just now to make a restoration. That's all. But it's not that always easy. There is actually one problem with this work when you receive cases like this. It is you need to work that not to destroy it. So how it's perfectly done, then every move you make with prosthetics would not harm this kind of nicely firm tissues. So what is the key to achieve this nice aesthetic result where we see now on the screen? What prosthetic things we must do in order to, to keep up with the perfect surgery which was done before? Algirdas has mentioned a little bit about our project, which we do, it's Zero Bone Loss Concepts, and it's a combination of different factors, surgical ones and prosthetic ones, how to achieve and to maintain crestal bone stability. But it's better to put in X-rays. When you see the 2011 and 2019, we don't even talk about bone loss. Like what we're talking about, we are having bone gain. So what things are important to achieve this kind of outcome? Well, from prosthetic factors, I would like to emphasize 4 things, which we will briefly discuss here. Connection, cement or screw retain selection, what is most biocompatible material, emergence profile, and barrier base or height of tie base. How do these things match together, and what is the role of prosthodontist over here? So let's start with a connection that why do we need it to be very stable? Well, we all know different connections, external, internal, open, closed conus, depends on our preference. However, what we have learned from previous 2 presentations is what you see. You saw immediate placement. And what is that? Implant is always subcrestally. And when implant is always subcrestally, then you have different environment than if we compare it to at the bone level placed implant. And we all know that when you see here on the video on your left that if connection is not stable, imagine this movement going on deep in the bone. So the deeper the implant is placed, the more connection stability is important. And like here, if connection is stable, you see subcrestal implant placement and really nice remodeling of the bone, reaching neck of the implant, but no bone loss, no bone resorption below the implant neck. And that's not always the case. When you see different systems and both implants placed below the bone, but in one case we see stable bone, remodeling and no bone loss, while the other you seeing bone loss. Now, there is a little bit additional procedure which we are taking during the surgery, actually after the surgery. Actually, I'm really glad that Algirdas is doing this because he's becoming a prosthodontist, finally. You know. After 15 years, he is on the right track. Well, so anyway, we do not really think about what we're doing with individual healing abutments because they are really better. Why? They provide a better stability. Because if we are using only healing abutment, all healing abutments have less engaging into our implant platform. That's why they are made. And we always have a better stability with the provisional abutments, which are usually used as a base for individual healing abutments. So that is also important to have a provisional crown or individual healing abutment in case the stability is not that good. But anyway, stable conical connection, platform switching leads to bone stability for subcrestal implants. Because when the implant is positioned, it really depends how the bone is reacting. If I would have to choose just a single thing, I mean, from all these 5 we discussed, I would choose cement or screw retain restoration. Actually, I would go more for screw retain restoration. And this is really was a big, my experience, and let's say this nice clinical case for many years, we've been struggling to get the aesthetics, and this is probably one of the first cases which was done early placement, and we were really able to develop a nice soft tissue profile. We made a restoration, and for many years I was proud and showing this as a success. Now I'm showing this as a failure. Why? Because just look at the X-rays. 2009, 13, 18, it was a bad year. A bad year because we had, for some reason, perimplantitis. So just think, 8 years, nothing's happening. Patient does not even remember that it was treated. But you see problem. And the problem was very obvious. We removed the crown, and you see semen remnants below the insubgingival part, not really visible on the X-ray. And not only semen remnants, look at the roughness surface of the abutment. So it means that this is an old gold casted abutment, so that's why these things are not biocompatible. So to finish up the story, 2019 was a better year, and you see that we have a bone remineralization. So of course it depends also on the quality of the implant and the quality of surface. So that's why we can expect these things if we really take the semen remnants away. The same patient, screw retain restoration, no problems, 10 years. So if we have 4 papers talking about this clear decision, screw retained, especially anterior region, and first of all, it goes into the direction of the implant. If you have a good direction, good position, it allows to make you screw retain restoration, so you are already satisfying one of the most important prosthetic factors. What about emergence profile? Well, Algirdas has touched a provisional restoration, and of course this is the key to develop a nice soft tissue profile to make the space for the grafting, and a really easy technique how to make it just to using liquid composite before setting. Of course, the most difficult work then is to reshape the crown, to polish it sufficiently that it could be ready to deliver to the patient. So that's just the beginning of the work. Now, as you can clearly see on this nice picture, you see that there is a tunnel of the tissues, and then the tissues go wider. So that's the shape of provisional restoration given to the shape of the tissues. And remember that we will come back to this tunnel when we talk about tie base height, barrier base height. But of course, you see this space where we'll have the tissues. When the tissues are healed and we are making final restoration, that's another story. Then you can apply a little bit of pressure because you need support. You need support for the tissues, because without it, it would be difficult to achieve adhesion, and we'll talk about that when we'll discuss biomaterials. If wrong height tissue T-base is selected, you can see what happens. You see nice bone above the implant neck, but too low tie base. This is just poor prosthetics. This is just poor understanding, because prosthetic rehabilitation of subcrestal implants is completely different from those who are placed at the level of the bone or above the bone. And this is really important, as I said, when we talk about immediate placement, because all implants are subcrestal. So no doubt that in a case like this, you see how wide and how low tie base is. We have bone loss, as we can see here. So when people ask me, how do I choose system which I work with? I always don't look at the implant in the beginning, look at the prosthetic things. So look at tie bases, how different tie bases height you have. So that's one of the key issues which allows me to select the implant system, because I know that I will be able to restore nicely different implants, different position of the implants. As you can see here that the tunnel made by provisional restoration should be occupied for the thigh base height. So the deeper the tunnel, the higher thigh base in the gingival part should be selected. And of course, this tunnel gives you the chance of the implant placement depth. What is also important that even in the provisional stage, we would have a different soft tissue height, gingival height. And here, it's a real case. You can see the all implant, all the part below the bone should really contact the thigh base. Now, one of the final things what we need to discuss is, of course, biocompatibility. We cannot just talk about thigh bases or different things without touching the material from which the crown will be made. And I want to just show you a little video about here that the situation was here that we had to remove the implant due to the failed immediate loading. And with that loading we saw that some tissues were adhering to the multi-unit abutment. And then we removed this abutment. And you can see that actually all our tissues can be divided in two big zones. We're talking about the adherent zone, the zone where we want to have some sort of contact or some sort of attachment, I don't know, some sort of a gluing of the tissues to our prosthetic restoration, and plaque zone. So this is really why do we need thickness of the tissue. Algirdas was talking about horizontal, yeah, but of course it's important to have vertical because we have a chance really to increase our adherence zone. Maybe there is a material which really can influence the strength of adhesion, that to be difficult for the tissues to detach from certain kind of material or restoration, and that would strengthen our protection. And also this is very, I think when I saw this video, it's like an explanation what is biological width. You see two distinct zones on the abutment. Plaque zone, contamination, where there is no attachment, nothing can happen there, and clean zone, where you can have adherent zone. So that's why it's important to have tissue thickness, but also think of this, why it's important for us to select the material. And this is our goal, to have adhesion, to have almost no sulcus. Tissues really are glued to the surface of abutment and restoration. This is the implant restoration. Of course, this is one of the best cases. Come on, you try to show where we have the best. But when we compare different materials, you can find that, for example, here, different in tissues contact to zirconia and tissue contact to glaze or metal ceramic. While we sometimes remove the zirconia crown, we can see remnants of the tissues on the crown. While we can sometimes remove metal ceramic restorations, you find the breakfast, yeah, or supper of the patient. So that's the difference, and these materials we can control and choose. What about biocompatibility of zirconia? And because, yeah, that's no question. Everybody is using it, and that's the material of choice. This is the case, it's 10 years old, which convinced me that we must work with zirconia and do research in that field. Because after the cementation of the crown, 10 years ago, we were still doing cemented. You see a gap which was produced because we had supragingival margin for abutment. Now we do it on purpose. At that time, we were really not doing that. And you see, after half a year, patient came back, and there's no zirconia. The tissues have ripped up and closed it. This is how it looks after 10 years. Excellent. You almost want to kiss those tissues because they look really efficient, quality, and look at the bone stability. What will happen to this implant? Nothing. I mean, it really will stay there forever. Different things why zirconia is really unique material. Structure, low adhesion of bacteria, vice versa, better adhesion of fibroblasts or epithelium cells. But from my point of view, the best quality of zirconia is its polishability, that you can see that from the rough status which we receive zirconia from milling center, it can be smoothed to the mirror-like, glass-like surface. Now, of course, it's a discussion. Do we need to have it so smooth? I mean, because there are different opinions. I mean, some researchers say that you need to roughen it to have a better attachment of the tissues of the cells, imitating something like a cementum on the tooth. But I think that the bacteria will be faster than your cells, and you will, with rough surface, you will have a better adaptation of the bacteria, not on the tissues. Remember what we have seen on the video with rough golden abutment, and it also influenced the perimplantitis. So what I see around our super polished zirconia crowns, I see a great adaptation of the tissues, and I invite you to do a just simple test, an ear blow test. You put a ear near the sulcus of your crown, and if it's polished zirconia, you will see that it's, when you press it, is not lifting. The tissues are not flabbing and really have good contact with the crown. So that's the power of things of polished zirconia. To visualize it, and when we'll talk about what cells are important to achieve this adhesion, this is how porcelain or glaze looks under magnification and zirconia. And when we find out that actually epithelium are our protective cells, and we must talk about, first of all, epithelium cells which line the surface of the abutment, not connective tissue, not fibroblasts. Fibroblasts are located below 1 millimeter above our implant level. And we all know that epithelium really likes the smooth surface. So when you combine smoothness of zirconia and smoothness of ceramics, you can really explain this. Now, how to maximize the contact? I mean, if zirconia is good, how do we maintain this tissue stability which was developed by the perfect surgery? Maybe a stupid question, but you know, like you can have different restorations, like zirconia without zirconia restoration, when all zirconia is hidden inside and glazed by porcelain, or real zirconia ceramic restorations, where you should see a clear mark between zirconia and ceramics or emacs or glaze. It's a matter of your choice. So you can nicely see here, this is correctly made zirconia restoration, because this part will be below the tissues and will have real adhesion, or chance to develop adhesion, because without that, we don't have a chance to have it. And developing all this because starts from the wax up, and more, we sometimes go back a little bit in time and technicians do manual waxing to prepare the framework of zirconia, because then we must really stay strict on the surface, how zirconia deep is below the tissues. What effect it gives? Delivery day and the years follow-up, you see a nice bone stability. And of course, I'm not going to say that it's only zirconia's fault. No, there's a process, there is a different things, but if you compare delivery day and 8 years follow-up, you clearly see better bone stability with time, and I'm sure that zirconia has played a role over there. Now, there is a very interesting research coming from Belgium, and I always cite it and always show it because it really is in alignment with why I'm talking. So the idea of the research was that after half a year of function, researchers have removed the restorations done in a similar way, tie base, polished zirconia and ceramics only on top for the aesthetics, and they looked what kind of cells do they see at the surface of zirconia. And guess what? They found epithelium. Epithelium is a protective cell which really glues to the surface of the material. And if we have zirconia and polished zirconia, for the epithelium, it's much better than the rough surface. So we have the adhesion of the fibroblasts just 1 millimeter above the implant, above the bone level. And you will see what amazing things really polished zirconia can do to the tissues. Immediate case, provisional restoration, final restoration, and you see with time that the tissues are getting better. So you see the rim of attached tissues increasing, and that again gives you a perfect bone stability. Another case, you see, almost you need soft tissue graft for this, but we restored the restorations with a zirconia, polished zirconia, and after 1 year, I'm calling Algirdas and saying, hey, we don't need soft tissue graft. I did it by myself. So with this, I would like to summarize 5 things: stable connection, polished zirconia, gingival height of the thigh base, concave profile of the final restoration, and that really gives you the final, diamond in all the story, perfect restoration and perfect soft tissues. Thank you very much.